A very good morning to all of you. We'll start straight away with the questions. After the technological lecture, we just had the wonderful lecture, we'll come back a bit to basics. How many of us feel that an unconscious patient can feel pain? Right, I have my work cut out. The next question. Do you use opioid-free anesthesia in your practice? And this is not for the routine spinal anesthesia cases, where they are indicated, as we've been taught. How many of us are thinking of opioid-free anesthesia? So that's 4. No, but willing to learn more about it. Great. So in the next 20 minutes, I think, was the talk? Yes. So the next 18 minutes, I'll be taking us through something about what its proponents are calling it as a paradigm shift in anesthesia. People who believe presently in opioid-free anesthesia feel that it could be something that changes the way we feel and think about anesthesia. We'll see why opioid-free anesthesia is making rounds, where and where not to use it, how it is to be done, if at all, and what our experience is at our center with OFA. Opioids have been around for more than 4,000 years. It's been called the plant of joy, and none other than Sir William Osler has called it God's own medicine. That standing there is Hypnos, the Greek god of sleep, and wherever he's pictured, he's seen to hold a pod of poppy or a branch of the opium plant. So much so that opium became so popular that in the mid-19th centuries, parents in England were routinely giving something called as Godfrey's cordial and many other cordials from different names, which had opium to give to their children so that they would be quiet. And they were so quiet that they stopped eating and became malnourished, and morbidity increased greatly. By 1805, Sir Turner first isolated morphine, and morphine was called morphine after Morpheus, who's son of Hypnos, whom we saw in the last slide, and he is the god of dreams. Leading American textbooks of the time exalted morphine as something which seems to make an individual a better and a greater man for some time. They compared it and said it was better than alcohol because it's not, the excitement it causes is not uncontrollable. So it was good, however, it had problems. People realized that even if it was like kissing God, they would die young with it. So they tried to search for better options, and they thought heroin could probably cause less addiction. However, it was so good, they told you not to take it. And so the story continued. Opioids in general, we know, have a potential for widespread misuse. They cause addiction, so much so that recently WHO has removed pain as the 5th vital sign because of the misuse that was resulting from it. We have heard of the opioid epidemic in the America and Canada, increased deaths from commonly prescribed, medically prescribed opioids. And it's not just in the West. In South Asia, in India, prescribed opioids are creating an epidemic of addiction and addiction-related problems. What about opioids in anesthesia? In anesthesia, synthetic opioids were introduced in the late 1960s. And the birth of opioid anesthesia is an interesting story. I'll take a minute here. The reference is there. It's a great article. Please go through it. But just for those who probably won't, Beaches was the first professor in Mass General Hospital, the first professor of anesthesiology. At that time, he wasn't getting many doctors or residents to take anesthesia in America, so they took their doctors, pioneers in anesthesia, from Europe. Doctors who had hand-ventilated patients in the polio epidemic in Denmark, who were interested in intensive care, and they started the first respiratory center at Mass General. At that time, patients used to die left and right after induction in cardiac surgery. They realized that if perhaps they could keep the patient ventilated for 24 hours after surgery, the outcomes would improve. So there was a spate of every patient being tracheostomized. Then Professor Beeches thought, maybe I could keep the tube in situ and extubate him after 1 day. For tube tolerance, they started using morphine, so to allow the patient to keep the tube in for a day. And then they realized that they could give huge amounts of morphine for tube tolerance without hemodynamic instability. So they slowly started giving it intraoperatively and increased the amount intraoperatively, and they realized it was wonderful. They also did this study, the graphs are there, which probably no ethical committee will allow today, where they gave up to 1 milligram per kg, that is 50 milligrams of morphine, to a group of normal patients and a group of patients with severe aortic stenosis. That was the group of patients they got mostly at that time. They were not ventilated, none of these patients, so the doctors actually stood there and shouted at them to stay awake. They put a pulmonary artery catheter and measured the hemodynamic indices. To their surprise, they found that fine, in the normal patients there was no hemodynamic alteration, but in those with aortic stenosis, actually the blood pressures improved, the cardiac index improved, and of course this was because of the SVR going down. That was how opioid anesthesia started, and that was how opioids entered in a big way into anesthesia. The component of cardiovascular stability, autonomic stability, and also analgesia. But analgesia, mind you, was not the first thing, the first reason why it entered anesthesia. And then many other synthetic opioids came into the market with the latest, most of them by the great Dr. Paul Janssens, and the last one, of course, in the line was 1994, the discovery of remifentanil. As these newer opioids were discovered, we also started realizing that they have their own flaws. And with these flaws, most of which we are well aware of, the exalted position of the opioids is now being questioned as the availability of newer, better agents since 1960s is there for us. What is anesthesia? The three pillars: we need amnesia, we need immobility, and we need autonomic stability. We get amnesia and hypnosis from the inhalational agents, propofol, and the other induction agents. Autonomic stability, or loss of response to the nociceptive stimulus of the surgeon, is what the opioids were used for. And the immobility was provided by the muscle relaxants. Now, the new paradigm we're talking about here says we do not need analgesia to achieve hemodynamic stability. If you're unconscious, really unconscious, it's impossible to have pain. That's the difference between anesthesia and analgesia. You are unconscious, you will not have pain. If you're monitoring BIS and if you're titrating it, you're unconscious. Why would you have pain? And for the hemodynamic stability, you can use alpha agonists, lignocaine, and a gamut of other drugs which are now available, which are safe, and which will give you what you want as an anesthetist. Why did this start? Opioids, apart from the problems we saw in the last slide, started showing some other interesting properties. As far back as 1979, there were seen to be receptors on the T cells, and later it was seen that it could cause clinically relevant immunosuppression. Morphine was seen to decrease natural and acquired immunity, and it was seen that it could affect the outcome of surgery, especially in vulnerable age groups. If you are an elderly, if you're immunocompromised, the chances that your outcomes are affected by being morphine were seen to be high. Morphine-induced hyperalgesia is a real phenomenon, a paradoxical response to the opioid agonist. It may happen where you're trying to treat the pain, or it may happen generally. Your whole body response to pain may be exalted. It's because of hyperregulation of the opioid receptors. There are many good standard evidence to show that this is a clinically relevant thing. Then there are other things like fentanyl-induced neurologic sequelae, which have forced us to think about whether we need opioids. So what we need perioperatively? During the surgery, we need hypnosis, hemodynamic stability, and immobilization. High-dose opioids earlier were the simplest method to reduce the use of hypnotics and get hemodynamic stability. Therefore, we thought that we needed it as an analgesia, and it became the third cornerstone for anesthesia. Now, this is what the paradigm believers are saying. Post-operatively, however, we need analgesia, we do not need hypnosis, we don't need muscle relaxant. Again, over here, opioids are not necessary. We can get this by many other better drugs. Avoiding opioids now is possible. We can use direct sympatholytics, clonidine, dexmedetomidine, beta blockers, indirect ones like lignocaine. Non-opioid multimodal analgesia is very much possible and available. And there is evidence for that. In the last 10 years, we have seen the effect of dexmedetomidine and clonidine on post-operative opioid use, significantly decreased use of opioids here, and on the pain scores. You can avoid opioids. The effect of ketamine has been seen to be also very good in decreasing post-operative opioid use. The other drugs, there's enough evidence out there, I've just mentioned a few. Magnesium sulfate can decrease requirement opioids intraoperatively. Lignocaine and steroids also would decrease post-operative use of opioids. The next few slides are taken from the presentation of Muller in Bruges in late 2015, where he was speaking about, in Brussels, they're doing opioid-free anesthesia for hyperbaric, for bariatric surgery, yes. And there they did a questionnaire-based survey to see how many countries in the world were using opioid-free anesthesia, and 26 countries at that time were. The main reasons why these doctors wanted to avoid the opioids perioperatively, we have all heard about ERAS in the talk here. Respiratory depression, they wanted to avoid post-operative hyperalgesia, chronic pain, cognitive disorders, increased chance of cancer metastasis with the use of opioids, just because it is possible, and the effects of opioids on brain. When asked what methods they were using to reduce the use of opioids, the commonest answer were they would add additives, combine it with a regional, combine it with local infiltration, monitor BIS or anesthesia, titrate their induction agents and the maintenance agents, and others. If they were adding additives, these were the commonest additives they were using for general anesthesia to avoid use of opiates. Now, when asked if they were not using opioid-free anesthesia, what were the main causes? Predictably, the answers were because there were insufficient guidelines, there was no training, and because the outcome was not proven. Of course, this is a new field. They're trying to convey, call it a paradigm, so these are expected. There was a question of awareness during opioid-free anesthesia, but there have been recent studies which have shown that if you can monitor and titrate the BIS and keep it less than 60, then that is not a problem. Remember, the early group who were doing the cardiac anesthesia in Mass Gen, the very reason opioid anesthesia came into the shadow was because a majority of those patients who had cardiac surgery later complained of awareness during anesthesia. So we come to the indications of opioid-free anesthesia. What is it being used for the world over now? Morbid obesity is the most important reason why they're using opioid-free anesthesia, the bariatric surgery or other surgeries on these patients. COPD, asthma, respiratory insufficiency, patients who are acutely or chronically addicted to opioids, those who have histamine release with opioids, CRPS, oncosurgeries, and where we are using the ERAS protocols, we would like to avoid opioids. Contraindications are really few. If you're allergic to a component of the regimen, which might include magnesium, lignocaine, esmolol, if you're allergic to one of the components, you may want to avoid opioid-free anesthesia. Acute coronary artery disease in anticipation that perhaps the hemodynamic instability will be there, which you don't want. And if you're anticipating the need for hypotensive anesthesia, again, there are question marks there. There could be contraindications to this. So the protocol they use in their bariatric surgeries, this is just because it's very beautifully described online. and just to have an idea of what people are doing when they are giving general anesthesia and not giving opioids, is to use something called as a Mueller's mix, he calls it that, and they add 3 drugs, dexmedetomidine, lignocaine, and ketamine, and they give it as a bolus and follow an infusion after that. Magnesium sulfate, induction and maintenance with propofol followed by isoflurane, paralysis with rocuronium, and monitoring of the neuromuscular blockade. They use metoprolol and nicardipine if there is hemodynamic instability, and they end with wound infiltration with local anesthetics, which of course is titrated to match the toxic dose because they're already giving lignocaine intravenously. And they say, and it's there in print, that it works beautifully. We have started using opioid-free anesthesia in a certain few indications. In the last 2 or 3 slides, I'll just take you through that. We started thinking about it about 2 years back when we started using PEX block and paravertebral blocks, ultrasound guided, for breast surgery. The analgesia we found was so good intraoperatively and perioperatively that we started wondering why give anything else at all. So there was a phase where we were doing it awake. We found that the patient was not very comfortable, so we induced the patient. And then we realized that the analgesia after the patient woke up could last for more than 12 hours. And so we thought, let's not give any opioids intraoperatively and see. So we took, this is the first, this actually we have sent it out for publication, so I will not be giving all the details here, but in a group of 25 patients each, adult patients undergoing modified radical mastectomy with axillary dissection, one where routine GA was given with opioids versus opioid-free anesthesia with ultrasound-guided block. Now, we did not want to give dexmedetomidine and lignocaine intravenously. We just thought if a block is available, why put it all into the vein? So the lignocaine with adrenaline and the dexmedetomidine were a part of this field block, 30 mils of the drug. They would be absorbed slowly into the blood. And we used beta blockers to take care of the tachycardia if it occurred. The first phase, we were not monitoring the BIS, so we did not paralyze the patients. And if there was any movement, we would give the opioids. Surprisingly, we realized we did not have to use opioids, really, in most of the cases. The block is very easy and it's very successful most of the times. When we compared the 2 groups, we found that there was a marked, significant difference in the rate of postoperative nausea vomiting, in how fast you could discharge them from the hospital and from the postoperative care unit, and the amount of analgesia they required postoperatively. Many times, for the next 24 hours, they did not even need paracetamol. And these patients, where you know it's very important in a breast cancer patient to be able to actively move their hand, could really do all kinds of arm exercises without any analgesia. Was vis-a-vis general anesthesia, where the requirement for postoperative analgesics was quite high. We thought it could be, and like the other studies show, Hontor et al. Have seen similar results when they have compared it. This is without blocks, mind you, and they have found that in opioid-free anesthesia, the requirement for analgesics postoperatively is very less. We have extended our study. We are comparing with different kinds of blocks. Over here, the only thing I want you to see is that if you're using it for postoperative this kind of opioid-free anesthesia with a block, then the analgesia consumption is as less as 1.2 grams of paracetamol in the next 24 hours. That is 1 dose. Sometimes you just give it intraoperatively and it is enough. And the duration of analgesia is as much as 800 minutes. Patient and surgeon satisfaction scores are both very good. This is what we do presently. For breast cancer patients, we have started using it for laparoscopic and bariatric surgery. After a common starting with midazolam and propofol, we introduce an eye gel. Some surgeons don't like the spinal reflex of a bit of a flinching on the right side. 1 shot of a paralyzing agent can be given. Routine BIS now we're monitoring for all the patients, keeping it between 40 to 60. Paracetamol 1 gram, muscle paralysis. Then we titrate the isoflurane, postoperative analgesia. In the next phase of patients, after we saw that 1 gram was enough, we are asking them to start eating immediately and take tablet paracetamol 650 grams. Usually they don't need more than 1/8 hourly. Opioid-free anesthesia is possible. It needs a change of mindset and adaptation of practice. It is definitely better for some patients and may be suitable for most. More research is, of course, on way. With that, greetings from Orissa and AIIMS Bhubaneswar. Thank you.
Thank you, madam.